Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. I'm your host, Dr. Andy Cutler, and with me today is a very special person. Not only a good friend, someone I've known a long time, but somebody who has been speaking about, writing about, thinking about switching for quite some time. And Peter, I don't want to make this sound like a career achievement award or something like that, because you're still very active and very vital. But how are you today, Peter?
Hey, I'm very well. Thank you, Andy. And thank you very much for inviting me. This is a great series, by the way. You're doing a fabulous job with this podcast, and I've learned a lot from listening to other podcasts. And so thank you very much for inviting me.
Thank you. We have a team, of course, that helps me do this, and I like to learn a lot too. Well, why don't we start with a question that you mentioned to me earlier? How did you get into this area? What was sort of got you interested in this idea of switching antipsychotics?
I sort of stumbled into it, Andy, and this is now going way back. So in the early 90s, the only atypical was clozapine. And then I was a sort of ambitious associate professor trying to do research, not being able to get NIH funding. And so I started getting industry funding to do the atypicals like risperidone, olanzapine, all of the post-clozapine atypicals. I had a sneak preview ringside seat as an investigator, as did you. And so, several things happened in these studies. One is that patients did just incredibly better. Now, I know that there's debate about atypicals versus conventionals, but don't forget, at that era, no one had been on an atypical. So the degree of response, we just had one amazing response after another. But then the problem was we would screw up. I don't mean deliberately, but if however the patient did not go over to the other side, and what I mean by that is we couldn't complete the switch so that the person had the opportunity to take it, it would be like, oh my God, the person's missed this opportunity. So there I was thinking, okay, well, as an investigator, I'm not developing these drugs. I'm not going to be what can I contribute? And I realized that in a few years, clinicians would get these medicines and no one would know how to switch to them. So I started collecting cases and publishing it. And I had the benefit of just publishing this before anyone else did. So I then became, sort of Dr. Switch early on. And a lot of the stuff that we're going to cover in switching today is sort of basic sound psychopharmacology plus knowing your patient and knowing how to adapt what you're doing to what the patient's needs are and what their issues are. So you're going to hear a lot from me about, things I've developed over the years, partly as education, ways to remember this, trade-offs, and so on and so forth. So that's my background. So it was very helpful. I think it was very helpful to the patients. It was also helpful to my career. So it is, near and dear to my heart. So I'm very pleased that we're bringing this up again now as new medicines, new questions come up about how to switch to different mechanisms.
Peter, those original studies we did, we would just stop the previous antipsychotic. There was sort of no guidance on how to do that, and they weren't switching studies. And I remember when you were involved in some of the very first pharmaceutical company-sponsored switching trials, and you published some of those.
Yeah. So here's what I think people need to know in terms of switching. There's no, the concern. Here's the concern: if you do what's called a cold turkey, you go from drug A to drug B. you're going to get a lot of withdrawal problems from going off drug A. It's also psychologically jarring for the patient. And there are going to be new side effects. So it's almost like chopping the tail off the dog at once. Now, I want to say that you can do that approach if you need to. The switching studies show that you can do it, but there's a couple big caveats. The biggest caveat is one that I'm going to return to, which is stay at therapeutic doses at all times. So if you can, you have to, because we know that even a few days of under medication in schizophrenia raises symptoms, destabilizes the patient. So if they're on a therapeutic dose of whatever they were on, don't lower it or discontinue it until you're at what you believe to be a therapeutic dose of what they're going on. And you can do that quickly or slowly. There are pros and cons to either way. The chop the tail off the dog gets it done quickly. You go from one to another, but you can't do it with a drug that has a slow titration to therapeutic. So, for instance, iloperidone is a very nice, Fanapt is the brand name. It's a very nice medicine, but you have to titrate slowly because of orthostasis. So you can't really start at therapeutic. So in that case, I'd be keeping that one going. But the point is that you as the clinician, most of the time, can work with the patient. And the main thing to tell the patient is you need to be at therapeutic at all times. And you tell the patient what the therapeutic is. So one other things, and again, the other thing I'm going to keep getting back to is psychological management, which can screw up the switch as well as any mess up in psychopharm. So for example, if I'm a patient and let's say I am like told that this new medicine's the greatest thing, new shiny object, blah, 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 right? And I'm sick of my old medicine. Oh, if I take another day of Zyprexa or olanzapine, I get fat. Or if I stay another day on Haldol, I can't stand it. And so you do a cross taper where you overlap. And what is the patient going to do? They're going to say, okay, I am so done with my old medicine. They will stop it early before you're at therapeutic. So you have to tell them that. The other thing you have to tell them is you need to balance optimism. Why are you switching? You hope something's going to get better. But you have to, with some caution, that it's an investment, that there may be side effects that come and there may be withdrawal effects. So that there may be problems ahead. And that usually doesn't mean that the medicine won't work. It just means that they need to power through it most of the time. So if they abandon a medication, let's say you're switching from risperidone to, I'm using old medicines, but switching from risperidone to quetiapine, right? Because you have EPS. Well, okay, you put the person on quetiapine, they get sedated, they don't like that or whatever. And then they get a withdrawal dyskinesia because they are going off a high dopamine to a low dopamine. They say, hey, doc, oh, you told me this would be so great. I'm now asleep and writhing. Thank you very much. And then they abandon the new medicine. That is heartbreaking. I'll tell you why that's heartbreaking. Because the patient has taken the risk of switching and has not had time to get the benefit. So that's all bad, which then gets me also to risk is that usually there's risk to going off your old medicine, some risk, and there is some benefit to switching, either in terms of tolerability or the hope for better efficacy. So discussing that in terms of what you hope, what are realistic goals, what do you expect, what are the cautions, and again, balancing hope with realism. Most of the time, switching is safe if you have a patient who you're connected with, who can get back to you and so on, and you can do it safely. But staying at therapeutic is at all times is important. And another thing I used to say along those lines of education is, hey, if there isn't a medication error during the switch, especially if you're switching to a BID or a more complex medicine, if there isn't a medication error along the ways, that's a coincidence. That's an accident. Expect medication errors. Especially switching among orals that may have different doses, or so you want the patient to bring back the medicine, go over all that.
Now, it occurs to me, too, that sometimes we don't get the choice. Patients sometimes just stop their medicine cold turkey on their own, and then you would do what you were saying there. Yeah. But ideally, you have the opportunity.
Well, in a funny way, they made life easier for us. If they stop it on their own, right? Here's the challenge with stopping your med. Patient stops your meds on their own, and they come in and they're symptomatic. Actually, that's an opportunity because, in a way, the risk of switching is that they get sick. Well, they stopped on their own. They're sick. So now you can actually start a new medicine without having to worry about discontinuing the old one. I think that advice I would say to clinicians is, if you have patients who you think could benefit from a new medicine that might be a little nervous about switching, you might plan if and when they stop their medicine and come in, are you going to resume the old medicine or are you going to do something new? If you don't plan that ahead of time, you're probably going to just restart the old medicine. So think about that. And I think that's another advice I would give.
All right, let's back up a little. We've kind of just jumped right in, but what are the reasons a clinician would want to switch rather than continuing or raising the dose or whatever, trying to make the current one work? What are some reasons?
This took me a long time to figure out how do I say this. Okay, so, if the person has schizophrenia, there are few, and I know this sounds like 101 and obvious, but I'm going to put it into words. Okay. The chances are very good that the medicine they are taking, if they're taking it, all right, and is both effective and not effective at the same time. Here's what I mean by that. Is if you ask the question, is the current medicine better than not being on medicine for this individual? The answer is probably yes. The person's getting benefit, and the patient's being helped. I'm talking about switching during maintenance phase. Patient is stable but not well. If you ask the question, on the other hand, so in that way, the patient might be a responder to the medication, the old medicine that you're thinking of ditching. On the other hand, if you ask the question, has this medicine restored the patient back to having no symptoms of schizophrenia and virtually no side effects? The answer is usually no. So the way I view it is most patients who are in maintenance phase are both responders and non-responders to the medication that they are currently on. And you could then say, so here's a tip I would give. There's always going to be a reason to switch, which is finding something that isn't working on the current medicine. And there's always going to be a reason not to switch. They have some, and when I say always, I'm being a little dramatic, but, bear with me. So there'll always be a reason not to switch, to hold back. So it's really a weighing. And now I'm going to give people a practical advice. So what I would ask is, what is the primary problem? What is the driver of I even thinking about changing this medicine? Okay. And to generally divide this up into, is it efficacy related? Does the person hearing voices? Is the schizophrenia not as well controlled as you would like? Or is the primary reason tolerability related, like person has gotten huge weight gain or has a prolactin problem or is stiff and slowed down or what have you. Is that the real driver? And so the approach is different. If it's an efficacy thing that you want to switch, first of all, just make sure that, doing something easier, if the person is having lots of symptoms and they're on 2 milligrams of risperidone and you know that many patients are doing better than, I know this is obvious, or you're not sure about adherence, maybe put the person on a long acting of the same medicine, something like that. So make sure your person is optimized. But if you're switching for efficacy, what you're doing, is making a wager in the sort of the goddess of efficacy. What you're wagering is that the individual response, the differences between these meds on individuals, is such that the next medicine you're hoping will be more effective than the previous one. We're not counting clozapine, which is the only medicine that is for treatment-resistant patients. We're talking about switching for efficacy-related reasons like persistent psychotic symptoms or stress-related psychotic symptoms in someone who is optimally controlled on a first-line antipsychotic. You're hoping that, hey, the next one will do better. The problem with an efficacy switch is that I don't know of any literature or any way to know in advance, if the person has not tried the medicine you're considering, to predict who will, on an individual basis, who gets better efficacy. I'd say in general, like olanzapine is maybe a little bit more efficacious, or, we all have our biases or thoughts on this, but you don't know ahead of time. So in a way, what you want to do is to tell the patient that about this bet, that it's probably a bet that is worth taking, or often is. And I'll explain that. So imagine, and I'll tell you what I would say. Imagine you have a patient who is on risperidone, Halo, whatever, and that's the only medicine they've been on for 10 years, and they still have voices, but they are stable, right? Would you make the bet that maybe the next medicine would be better and say gets 10% better control of positive symptoms, 10% better control of negative symptoms, or maybe they don't need cogentin so they can think more clearly on the next medicine, right? If you find something that works better for them, that could be a lifelong benefit. But the risk is immediate. So the problem is that an efficacy switch, you have immediate worries about will the next medicine hold the patient, but potential benefit, but you can't predict it. That's kind of that's where going to therapeutic is so important. And I think that for those switches, you really, in my opinion, should try for monotherapy of the next agent. But remember, that's one big bucket is the efficacy switch. Spoiler alert, tolerability switches are very different.
We all know that some people do better with one medicine than another, but as you've said, we don't have a blood test or a biomarker. We don't know. So we are making a little bit of an educated decision, a little bit of a leap.
Okay. So what I'm talking about tolerability switch is, if, and again, the classic case of this would be the person who's done better on olanzapine than anything else and has gained 50 pounds, right? I mean, so you have, depending on how you look at it, you have an efficacy win and a tolerability disaster because that's going to kill the patient. Or, and again, there are various things. Or you have a young man who has retrograde ejaculation who wants to go off risperidone, and I'm picking a side effect that is not medically serious but is a deal breaker, or galactorrhea, amenorrhea, something like that. You have a single, kind of a single thing that is prominent And the efficacy may or may not be good. Okay. But let's just say, for the sake of this podcast, you have an individual who has a side effect that they can't stand, and they have reasonable efficacy. So now, what do? It's almost, you have a very different set of issues. If an efficacy switch is not predictable, tolerability switches are incredibly predictable. What you need to do is look at the medication profile of the medicine you want to switch to, and look at the profile of the medication that you're thinking of switching from. And if you get the patient on the next medication and they stay on it, the side effect that's the problem will melt away. Now, there are some nuances to this, but it is reliable. You can tell the patient that. If I have amenorrhea, galactorrhea on risperidone and I go on aripiprazole, you can guarantee it will go away eventually. If I have gained a zillion pounds on olanzapine and I can go on, say, and I'm using older medicines in the era I was doing to avoid sort of the new competitive stuff. If I can get someone on ziprasidone, if it will eventually, it's not the ziprasidone in this case, which is more of a weight neutral. It's not so much it's a diet pill, but it will basically take away the poison, take away the thing that is gaining weight. So you'll have a reversal of weight gain. Now, that reversal, let's say with weight gain, will be as much weight gain as the person gained on olanzapine. If you started out fat before olanzapine, no diet pill, but it will reverse. So that's really, really helpful. Okay. So you're much better able to predict by what medicine you choose what the side effect profile is. Now, it gets more complicated than that. Okay. But if I can, I'll give you, that what I've done is tolerability switching 101. Let's get a little bit more tolerability switching 201, or a little bit more advanced. Here is the problem with what I've just said, is that I am absolutely confident what I've just said is true, but it ignores the fact that these medicines don't have one side effect. They usually have several side effects. So you get into what I call the whack-a-mole problem. I'll give you I'll give you, again, using the old switching studies I'm familiar. If you have let's say you have risperidone, you have galactorrhea, and you have EPS, right? So you switch to olanzapine, and the galactorrhea goes away, and the EPS, the Parkinsonism, goes away. You can predict that because of the difference between, but if the patient gains a zillion pounds, right, that's the whack-a-mole problem, that you may have some other side effect that becomes a problem. So it's a good idea when you educate patients and talk about switching, to consider the entire side effect profile. There's very good news for everyone now, though, is that when I was doing my switching work, which is, too many years ago, this was all in the early 90s, you really couldn't get away from the whack-a-mole problem. If you switch to the medicines were better, they were getting better, you could do more, but, in the last 10 or 20 years, the newer atypicals and the newer medicines are such that for the most part, it's no longer this false equation of, and again, I'm being glib, but do you make the patient fat or do you make them Parkinsonized?
Right. No, you're right.
You're poisoned,
That was right.
Do you make the patient
was it.
sleepy? Or, yeah.
Right.
We can do better than that now. So that's a really big advance.
Yeah. Well, you're right that the newer atypicals may not, on average, work better, but they do seem to have improved, I don't know, tolerability or safety in some cases, for sure. Peter, how do you decide, though, if you're going to augment rather than switch? I like that we talked about raising the dose if appropriate, but what about an augmentation strategy?
So I think what you're saying, if I'm hearing you right, is if I say switch, let's dissect what I really mean. What I mean by switch is an elective switch in which I have a patient who is responding to some extent, but has problems to some extent that I believe there's a decent chance I can fix by changing the antipsychotic. So an elective switch, elective change. And when I say the word switch, implied in that is I'm going to get the person off their old medicine and onto the new medicine, monotherapy. Does that sound fair? Now, I can call it, you can have a nervous Nelly switch or chicken switch. Let me tell you what a chicken switch is. I am so anxious last time I was off risperidone, I burned down the house and I'm not going to get off this stuff. The chicken switch is you would combine your next medicine for 3 to 6 months, get the person used to it. So you're doing a combination strategy and then slowly getting them off the previous drug. I think, by the way, for those of you who like to combine, and I'll get there, that is something that should be done more for people who are very anxious or families who are very anxious. And there's a difference between saying we're going to try to do that than, let's just combine and, till the cows come home. So, yeah. And I think it's good to articulate what you hope to do. Now, a few other cautions before we talk. So if I use the word, so this turns into almost like a religion or a political rift, because there are psychiatrists who are very strong believers in combo therapy, here's what I'm defining as combo therapy. Tell me if you think that's the case. The combo therapy is you're on therapeutic doses of 2 antipsychotics. I'm not talking about the patient who is on Abilify, but then aripiprazole and occasionally needs Seroquel to go to sleep. And Seroquel is used as a sleep aid, but it's not really a full antipsychotic, okay? And I'm not talking about combining clozapine, okay? So I'm just talking about, hey, I want to combine drug X and Y in therapeutic doses because I think that combo will do better than either one alone. So if I think that's a good idea, I call it combination therapy or augmenting. If I think it's a dumb idea, I call it polypharmacy, right? So embedded in our language is already our value with that. So it becomes like a philosophy. Now, I will just ask for those of you who believe that this is a good strategy, and I don't know, I tend to try not to do that for reasons I'll tell you, but I'm not trying to say, hey, never do this. But if that is your common strategy, I would just give you a few thoughts. It is not a substitute for clozapine. So if the combo strategy that you're embarking still leaves the patient very symptomatic, bite the bullet and go to clozapine. And if clozapine is complicated or you don't have the resources for it, then refer out. It is also not a substitute for a long-acting to see if the long-acting might have.
I was going to bring that up. I don't think we can call someone treatment resistant until we've tried a long-acting, because I think it's hard to take medicine every day, so you just don't know. Yeah. So I think that's wise to put that in your algorithm somewhere.
So, I would say look, I've gotten older. I have gray hair. I used to feel more strongly about this as not being the greatest idea. But there's one other caution is, if you are in a clinic and you're very busy, you're very stressed, and you have 5 or 10 minutes with a patient and you have to do something, don't just sit there and do something, right? The easiest thing to do is add something, right? It's easier than switching. So keep that in mind that, are you doing it for you or the patient? And it's okay to do it for you. But I would suggest if you are doing a combo, go ahead and do it. You believe in it. And here's what I would do. If you believe in it, be a therapeutic of both medicines. If you're going to do it, really do it. Make sure the person can handle the combo, both in terms of the, you're basically raising the number, of side effects and everything. So make sure it's going to be tolerated. I would have a stop number to know. I would stop at 2. Whatever your number is, I would have a stop number because otherwise you are going to get into back up the truck problems if you keep doing that. The other thing I would suggest, and this is also true of switching, is sort of try to make what are your expectations? What do you hope and the patient hope? And then if the person meets those goals, great. You keep them on that. That's your philosophy. Patient can tolerate it and so on and so forth. If the patient doesn't meet that goal, remember to get them off.
Right.
Well, you put them on.
Well, it's funny you say that, Peter, because I think sometimes what happens is people, I call it getting stuck in the switch. The plan is to switch over to another monotherapy, but they put them on the another medicine. They're overlapping, and the patient gets better. And they're terrified now to finish that switch and go all the way. Yeah. I think that happens, don't you?
Oh, of course it does. And it's understandable. I've been doing this too long. I have my own language for this. I call that switching purgatory. Right? You're sort of stuck and you don't know.
You're stuck in the switch. That's right.
And what I would say is there's a big difference between hitting the pause button or delaying finishing the switch, which is what I mean by getting them off their old medicine and just continuing to prescribe. You can see my biases there. I personally think a delayed cross taper for psychological reasons, person's too nervous, you're too nervous, makes a lot of sense than pushing faster than the patient can go. But I think it's a good idea to mark in a calendar and educate, say, look, it's now September. In 2026, early, I'm going to start recommending you, if you're doing well on this, going off the old one, okay? Just so you've heard it now. And I think that's a good idea. Again, for the same reason that switching is a good idea, right? The person has their life ahead of them. So that's my spiel on that.
Okay, it makes sense. Peter, we need to get into in a little bit the muscarinics because that's a whole different ballgame. But let me just run something by you.
Well, Andy, it is and it isn't.
Okay, yes.
A lot of the principles, be it therapeutic at all times, that's the same. Educate the patient at all times. Watch for medication errors at all times. Tell them what the early side effects are so they don't get blindsided. All that stuff, is not different. So we will talk about the differences.
Yeah. Well, people don't like surprises, so I like that idea of educating. Yeah. But I'm going to run something by you, and you tell me what you think. I have kind of codified this in a way of thinking about, first of all, what are the pharmacokinetic and pharmacodynamic properties of the drug you're switching from and the drug you're switching to?
Well, that's great. I really like that.
Yeah, because people sort of want cookbooky things, but I don't think you can do that. But here's how I think about it. I put them into 3 buckets. So there's the penes, which are relatively short-acting and have a lot of antihistamine and anticholinergic. There's the D2 partial agonists, which have long half-lives and not a lot of antihistamine and anticholinergic. The dones are sort of in between with their half-life, and they don't have as much usually anticholinergic antihistamine, but they do have anti-alpha. So you have the worry of the rebound kind of thing.
Right.
So I always feel like the penes I'm going to taper really slowly, unless I'm switching to another pene because of the risk of the rebound from that. The D2 partial agonists, can't you just stop those, because they auto taper. They have such a long half-life.
Like an LAI? I
don't know what you think.
I think so. Especially cariprazine, which, as I understand, has the longest if you include the metabolite.
It is the longest. All three are long, though.
Right. So, I think, look, if I were to do a 2-week cross taper or 1-week cross taper, maybe oral aripiprazole can fit that. If I was planning to do a 1 month, maybe not. So right. I don't know.
I see what you're saying. Yeah, that's a good point.
Here's the point. You do what you think is best, but keep the patient at therapeutic at all times. Either the old medicine, this is where it can save you, is like it can get like, which variable? If you want to start subtherapeutic on the new medicine, keep the old medicine therapeutic. If you can get aggressively to therapeutic on the new medicine, you can cut back on the old medicine and just do what is best. I think you brought up something very important. And depending on the sophistication of the audience, here's what you need to remember. Antipsychotics, many of them are antagonists of many different receptors. And there are two things to know depending on the receptor. One is that where the receptor lives is very important. In particular, if the receptor lives in the periphery versus lives in the brain, it's doing a different job. It may have the same name, but it's doing a different job. So let's take antihistamines. Is if you're doing it for allergies, right? That's in your peripheral mast cells and everything. But the side effects of antihistamines, the ones across the brain, the sleepiness or that's in the center. Now, you can predict withdrawal from anything along these lines based on it does the opposite of what the acute effect is. So if antihistamines make you sleepy, stopping them quickly will cause insomnia. If an antihistamine makes you kind of chill, stopping it suddenly will make you anxious. If cogentin treats EPS, stopping it suddenly will cause Parkinsonism. So what you want to do when you're getting someone off one of these medicines is just look at if you don't know it already based on experience or your training, you can look at which receptors are antagonized. And you will know that what the side effects will be from withdrawal of those receptors, pretty much. And that'll happen often in the first week or two. So that's really, really important. The thing that is different about xanomeline trospium is that, well, I guess the good news is pretty much all you need to think about is the muscarinic receptor, because it doesn't do much of anything else, right? So what that means is that if you're going off anything else, you're going to have withdrawal effects from whatever else you're going on in terms of known withdrawal effects. And that's okay. We all know how to handle that. You can either slow that. The main thing I think that makes there's several things that make the switch to, in particular, xanomeline trospium a little bit different. And one is look in the mirror, look at yourself. If you're an experienced practitioner who has done psychopharm, you're going to know switching other antipsychotics maybe like the back of your hand. It's a comfort level. You know what the side effects are. You know what the issues are. You know everything. And here's a new medicine that is like, you're not going to be so knowledgeable about this, maybe. And it's a little humbling. And so to take this medicine seriously means, studying it a bit So you understand the muscarinics and what happens with muscarinic withdrawal, all that. Now, the side effects are different with muscarinic drugs or anti-muscarinic drugs. So the main side effects of anti-muscarinics like cogentin is dry mouth, blurry vision, all that stuff. And constipation. A central anticholinergic will cause memory problems. The procholinergic, the agonism, the stimulation, we're not used to that as much unless you treat a lot of Alzheimer's with Aricept, where you get used to getting GI problems, right? Here's the way to remember this, is that a lot of the side effects of a muscarinic agonist, of any of them, which includes this, is that it overstimulates your parasympathetic nervous system. So what happens if you're overly vasovagal? You faint, you feel, you get nauseous, you speed up the gut, you get diarrhea, but a lot of GI stuff. So, and that GI stuff can be quite, unpleasant. Now, fortunately, it's usually transient. This is where the education about, hey, the bad stuff may happen before the good stuff. Now, the other thing you mentioned, Andy, is the quirk of pharmacokinetics. So here's the way I think of this. This works for me. Xanomeline trospium is a combo medicine. Okay, xanomeline is what does, in the brain, good stuff. What the trospium does is mitigate, doesn't eliminate, the side effects related to the peripheral muscarinics in the body. Okay? Now, the neat thing about trospium is it doesn't go into the brain and make you confused or undo that, right? So here is the way to remember this. The challenge is that both of these components of this combo need to be released at the same time, right? If you get into a situation due to drug interactions or anything where one is released and the other isn't, you're going to have more problems than usual. So that gets into this whole food effect business and the BID business. Okay, now I will confess, before xanomeline trospium, if someone told me it was BID or take it with or without food, it's easy to say, I've done this before, blow it off, don't take it seriously. It's no big deal, right? I can take this seriously. If you're going to prescribe this drug, take this stuff seriously because it really matters. So here's the problem with taking this medicine with a meal, is that trospium does not get absorbed. You're basically, if the patient takes this drug with a meal, you've gone from xanomeline trospium to xanomeline alone. And so you're likely to get more GI side effects. So if you don't, this is where this newness of a new mechanism, these weird PK stuff, here's the way to remember it. These two components need to be released together, and it's a little quirky. And one of the quirks is trospium goes away if you take it with food. Another quirk is the PK needs to be released together. It's a fairly short half-life, which explains the BID. So take the BID seriously. That kind of stuff, and prepare the patient. And so, so one thing is to know its quirks, know the muscarinic system a bit. You don't have to be like the world expert on muscarinic. You don't have to just sort of bone up on this. Because Cobenfy, the brand name xanomeline trospium, it's both a peripheral anticholinergic, which is what I call the antidote to some of the more severe side effects of xanomeline alone. and it lets xanomeline do its thing safely. It sort of allows xanomeline to be safe enough to use, and it's safe. I mean, if you think about the safety of xanomeline, if this is the biggest problem and not TD and not this and that, I mean, if you think about it that way, it's overall very, relative to the stuff we prescribe, it's very, very safe for schizophrenia. It's just that we're used to the crap that we prescribe. I don't mean that cynically. No, I'm not trying to say that. We're used to the risks of drugs we prescribe for 30 years. But if you take a step back and objectively say and weigh those risks, so that one last thing is the other thing I would do different is take an anticholinergic inventory before you switch. And what I mean by an anticholinergic inventory is you can do the med list. There are lists of which drugs are anticholinergic and see how much anticholinergic the patient has on board before you switch. And here's what I would recommend. Even if you never prescribe xanomeline, trospium, you get them lower on their anticholinergic burden, you've done them a big favor, right? Okay, we all know that now. That's common knowledge. But in preparing the patient for this switch, if the person is on an anticholinergic that you can safely offload before you do the switch, try to minimize the overall anticholinergic baggage the patient has going into the switch. If you can. The big one is cogen, right?
Right. But if you're going to do something with that, Peter, you got to do it slowly, right? You don't just rip the cogen off.
Well, that's the whole issue. Again, use your judgment. This is a difference. What I used to do, a patient was on risperidone cogentin. Cogentin is very toxic, causes memory problems. Let's say I put someone on Abilify or Seroquel, something that does not need cogentin relative to risperidone. I would keep the cogentin, the benztropine, going during the switch until the switch was done, and then I taper them off cogentin, right? The problem with that is you may forget to taper them off cogentin, but you should taper them off cogentin, right? What I do now with a switch to xanomeline trospium is if I can get them off cogentin earlier, and I say to the patient, look, you might feel a little stiff a little bit, I would do that. And what you're saying again is, do you do it quickly or slowly? Well, you know what rebound is. If you do it cold turkey quickly, they're all on a cogen, they're going to have Parkinsonism rebound. So those are the pros and cons. Okay.
Now, what are some of the unique challenges, I guess, of transitioning a patient from a dopamine antagonist to xanomeline trospium, which is not binding to dopamine receptors?
Right. Now, I want to tell the audience, this is not a new issue. Okay, guys, if you've switched someone from Haldol to Seroquel, or from Haldol to olanzapine, you've already done this, right? And what I mean by that is, even though the medicines we've prescribed all block dopamine to a greater or lesser extent, there are vast differences to the degree of which the dopamine receptor is blocked. So when you go from Haldol or risperidone to quetiapine Seroquel, you're going from a high D2N state to a low D. So let's just simplify this and say the brain thinks it's now off. It went from its dopamine receptors blocked to its dopamine receptors unblocked. What happens is, usually the person feels better, but from a movement disorder perspective, they will get withdrawal dyskinesia, right? So if you've ever seen this, when someone comes in, they start them on Seroquel or some other, or perhaps some of the newer ones that don't block, like Caplyta. I'm not mentioning Caplyta because I was in this bubble called the pharma industry, as I didn't prescribe it when it came out. simply because I wasn't prescribing, right? But I'm sure that happens with Caplyta, right? You're going to get a dyskinesia. And the doc will say, "You didn't tell me Seroquel or Caplyta causes dyskinesia." And then you say,
"That's right." You blame the
not
new.
that.
You blame the new
withdrawing
drug
from the Haldol.
That's right. Peter,
Right.
do you remember when aripiprazole came out?
Yeah. That's the same thing that'll happen with Cobenfy, I bet.
Yeah. Do you remember when aripiprazole came out? I'll never forget. People were switching rapidly from olanzapine, and patients got agitated, and they were blaming the aripiprazole. I remember this vividly. And I think you're right. The same kind of thing could happen here. That's a really good point. So you would carefully taper the previous medicine and overlap it with the xanomeline?
Again, this is the it depends on what your trade-offs are, right? If the patient says, "Look, I'm not going to take this, I'm not going to combine," a lot has to do with fitting it into the rhythm of what the patient wants to do. In general, I would agree with you. The brain doesn't like rapid change, generally speaking, right? So you could, so let's take xanomeline trospium, for example. The therapeutic dose of that for schizophrenia is 120. These are capsules. The first number is the xanomeline number. The second number is the trospium number. 120 BID. So if I say
100/20, not 120 milligrams at once, right? That's 100/20. I just want to be clear for the audience.
Thank you for clarifying. That's very important, right?
Yeah.
It's also very important to say BID, because if you get lazy and I say 120, I'm in /20, I'm implying it's once a day. No. So I would not lower or get rid of the previous antipsychotic until I got
Oh, I see what you're saying. Yeah.
100
because there's a tape.
BID.
There's a titration here. Yeah.
Yeah. Using the same rule of thumb that they need to be on therapeutic of either the old or the new. If I'm really nervous about, withdrawal from olanzapine or quetiapine, whatever it is, I'll do it more slowly once I'm at therapeutic. If I'm less nervous, I'll do it quicker. The same thing with the onboarding, right? If you're more concerned about what I call early side effects, and when I say early side effects, I don't mean the time of day. I mean when in the sort of cycle of switching. Early means the first week. If I'm more concerned about nausea or vomiting, if I feel like the patient will freak out, I might just start with the lowest dose, 50/20 at bedtime, not deluding myself that this is therapeutic, but I'm trying to get my foot in the door so the patient is more comfortable with this, and then slowly creep up. But if I'm doing that, I'm not a therapeutic. I'm not going to touch the old medicine.
Yeah,
until I get to therapeutic.
Yeah. The tough side effect with this drug being procholinergic, if you will, if you don't adequately cover this, is going to be nausea and vomiting. And what I'm wondering, Peter, is D2 antagonism is an anti-nausea mechanism. And in the trials, they kind of washed off the D2 drug. There was no overlap. And I'm wondering if overlapping them with the D2 might help a little with the nausea.
I think we're going to get the answer to that. There's the ARISE study. I think it's going to be presented. I actually think it's going to be presented this coming week. And I'm going to be looking very carefully at what because in the ARISE study, this is adding it to either someone's old antipsychotic. The up titration was slower, and they stayed on their previous antipsychotic. So maybe that will minimize the nausea. I don't know the answer to that. I do know that the slower up titration you go, the less you'll get. Right. It's not just what your absolute level is. It's how quickly you go up. It will be, those are two different risk factors. Again, I want to emphasize to everyone, this is not, Harry Potter magic. The idea of if you want to minimize early side effects to go slow to therapeutic is no different than what we have been doing for years.
That's right. Yeah. And of course, the pivotal trials were done with a relatively faster titration. They were inpatient, if you will.
Right. We're in a hurry.
You're right. Arise is outpatient, so you can maybe take your time a little more.
Yeah,
They've got something else on board. That's a good point.
So
Peter,
we might know. Thank you. Yeah.
Peter, unfortunately, we are running out of time. So I want to finish up real quickly with, how do you see that xanomeline, trospium is not the only muscarinic in development, as you know. It is on the market now, but there's others coming. How do you see these drugs changing the way we think about switching and treatment of schizophrenia in general, I guess?
Well, I realize
it's a big question.
The honest answer is I don't know, but as you know, I did work at Karuna, so I had about 3 or 4 years.
Yes.
I did have 3 or 4 years to think about this. We don't know, but I think in 5 years or 10 years, this will be a profound change. I think these drugs are different. I think this is realist. I don't think this is the same old bullshit, pardon my French, of slight variations. These are different medicines. They really work, but we need to understand them better and learn collectively about it. So I'm very excited about this class of medicines.
Yeah, me too. I mean, we have the opportunity for maybe some patients to do better from an efficacy point of view or tolerability bill. And one of the things about these drugs, and you alluded to this earlier, is there's short-term tolerability issues, but the long-term safety profile vis-a-vis the D2 blockers is pretty good.
I think, we don't know for sure, but, the 1 to 2 year safety, I call it, what you want of the long-term safety studies is to be bored.
Right.
Anything exciting is not good.
Not good, yes.
And best as we see with these long-term safety studies, they're very boring. Nothing new comes up.
Yeah. But as far as the things we worry about long-term, like weight gain, metabolic disruption, movement disorders, unlikely to see much of that.
It's really remarkable.
It is really remarkable. Well, Peter, what's remarkable is how fast this time went and how much information you packed into this hour. I really want to thank you. I always learn from you. You have wonderful twists of phrases and ways of codifying things. And we'll just have to continue the conversation. I hope the audience will learn more and read some of your papers. That would be great.
Yeah. And see you in a few days, Andy. Thank you so much for having me.
Yes, I'll see you soon. Thank you. Take care. And for more information about our podcast and our other educational offerings, please go to our website, which is neiglobal.com. Thanks for listening.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.